Good evening, sir.
Good evening, Sabah.
Yes, sir.
So I'll start whenever you tell me.
Yes, sir. Oh, actually, I'm checking YouTube. 23 people have YouTube link said 23 people are there, but another 5 minutes we will wait, sir, and then.
Sure, sure. Okay.
Okay. Good evening, everyone. It's my uh, privilege and pleasure to invite you all for this very important talk. And some people are connected through Zoom, and most of them are connected through YouTube also. So, without wasting time, I will say a few. I will introduce the speaker for today, Professor Gaurav Agarwal sir. He is my teacher. He is the president-elect of Indian Association of Endocrine Surgeons and past president of Breast Surgery International. Sir has got many accolades, and the topic is very interesting. And I hope all the people uh, and especially the MCH PGs and as well as the surgical PGs. This is what they want to listen from the master himself, and sir is there. So I understand today being a working day, already people are joining. Dr. Munir Wani also is joined. Okay, so we have quite a number of people, and I request sir to start his talk, and once he finishes, we will have a discussion with him. So over to you, sir.
Thank you very much, Dr. Sabaratnam. Am I audible?
Yes, sir. Audible, sir.
Great. So, first of all, I wish to thank um, both Dr. Sabaratnam, the Secretary of Association of Surgeons of Rural India, as well as all rest of the office bearers of ASRI, Dr. Natkarni, the President, Dr. Rashekar, Dr. Vice President, and Dr. Nan Guruswamy, the Honorary Treasurer, for this invitation for me to uh, participate in this event. I'm happy to share some of my thoughts relating surgical management of early breast cancer. Uh, I'm sharing my presentation. Is it visible? Is my
Yes, sir.
presentation?
Yes, sir.
Excellent.
Visible, sir. Visible.
Thank you. So the topic that I thought I should discuss with you all today is contemporary surgical management of early breast cancer. And I feel in this regard, less we do seems more or more beneficial for majority of our patients. So during the course of next 35-40 minutes that I have, I'll try to demonstrate to you why I feel less is better, less is more when it comes to treating early stage breast cancers with surgery. Before I go on to discussing the surgical treatment per se, a few thoughts about how cancers are managed today, especially early stage cancers and highly treatable and curable cancers like early stage breast cancer. I feel that the best way to treat any disease for that matter, and specifically these curable early stage cancers, is to treat them optimally and not maximally, as perhaps what used to be believed a few decades ago, when we would treat patients with maximal tolerated treatment. However, now we have moved on to a philosophy of treating with minimum essential treatment. We know that some patients cannot be cured even with maximal treatment. There are quite a few others who would do well even with minimal treatment. So, what is important is to find which patient belongs to which category, as in when possible, and then tailor the treatment to the needs of an individual treatment to arrive at the optimal treatment for that particular patient. And that is the kind of philosophy most oncologists work today, irrespective whether they are surgeons, radiation oncologists, medical oncologists. In context of treating breast cancer today, especially early stage cancer, what we believe today is to achieve cure as and when possible, and not just control the disease, not just palliate the disease. We are capable of treating with a curative intent in a vast majority of patients who do not have systemic metastasis at the time of presentation, and achieve cure in large majority of those. And because we are able to cure these patients, they will be surviving for long. We need to also keep an eye at their quality of life. It's no fun curing a patient but making her miserable from physical and psychological viewpoint. Uh, so currently, what I believe is the best philosophy is to not just add years to life, but life to years. We must make sure the patients who are surviving even after treatment for a cancer have good quality life, and that is why I feel we need to add life to years. So, preservation of quality of life is an important component or goal of treatment of cancers as much as ensuring good survival. And this we can do by avoidance of morbidity. Avoidance of cancer treatment related morbidity again becomes an important goal to achieve. So I now come to this gist of this whole presentation would be revolving around how less treatment is better, how it is more beneficial for majority of patients with early stage breast cancers. So because I'm talking of early stage breast cancer, it seems pertinent for me to define what early stage breast cancer is. I don't need to define because I feel that majority in the audience are quite well versed with these facts. But in a patient who has breast cancer, but the disease is limited to the breast and adverse to the axilla in a manner that it has not involved the chest wall or the skin of the breast. And if at all there are metastatic nodes, those are mobile and not matted, and they have not involved other echelons or other regions of lymph nodes. And certainly there are no systemic metastasis. Those are the patients whom we club together to this group of patients which we call early breast cancers. In terms of TNM staging, these patients who are called early breast cancer patients, they span the tumor stages of T1 to T2 with nodal stage of N0 to N1 and M0 or metastatic 0. Also, we include non-metastatic T3 tumors which are larger than 5 centimeters but are not associated with any lymphadenopathy and with no systemic metastasis. These are also considered early breast cancer patients. Now, how do we treat these patients? Surgery is indeed the mainstay of treatment of early stage breast cancer. However, this has to be part of a multidisciplinary comprehensive treatment plan and not as a standalone treatment. Of course, there are a few very early stage, very low risk patients where perhaps one can do well with just surgery and possibly with radiation and avoid any systemic treatment. But a vast majority of early breast cancer patients require a judicious mix of various forms of treatment, including surgery, radiation, chemotherapy, hormone treatment, and targeted treatments. Of course, selected specifically for individual patient. Not all patients require all of the treatment. And when we are deciding what is appropriate for an individual patient, we again keep in mind what is the minimum essential treatment for that patient and not the maximal tolerated one. We need to address surgically both the primary tumor in the breast as well as any lymph nodes in the axilla which may be metastatic, and both of these are important. Breast conservation is the desirable treatment today in majority. Of course, it may not be accepted by some, and there would be a few patients who are not suitable for breast conservation, either because they have multiple tumors or There are some other contraindications to conservation, and in such patients, mastectomy continues to be an important procedure to perform. It continues still to be the workhorse of breast cancer surgery. Often today, we treat patients surgically after having subjected them to systemic treatment, or what we call neoadjuvant systemic treatment or primary systemic treatment. And in this manner, the surgery is a post neoadjuvant chemotherapy or post neoadjuvant systemic treatment surgery. But quite a few patients with early stage breast cancer, especially those who have hormone receptor positive cancers and not triple negative or HER2 enriched cancers, they still can be treated with primary surgery, which means surgery is the first component of multimodality treatment. And this will be followed by adjuvant treatment in form of radiation and whatever systemic treatment. So before we start treatment for any cancer, and for breast cancer, we must establish a robust, foolproof diagnosis of the disease. And in context of diagnosing breast cancer, this is established by use of a triple test. The triple test. And the triple test, the three components are the clinical history and examination, breast imaging, which is usually in form of bilateral full field mammography with correlative ultrasonography in majority, and then arriving at a histological diagnosis using a core needle biopsy, where you use a specific core biopsy gun to provide or to achieve histological diagnosis, where besides the histological diagnosis, the type of cancer, the grade of cancer, and the various biomarkers like estrogen and progesterone receptors and the HER2/neu and possibly proliferation marker, that is Ki67, should be assessed. And this is the minimum information required for planning appropriate treatment for an individual patient with early breast cancer. A word about biopsy. Core biopsy, as I said earlier, is the preferred and the gold standard method of arriving at preoperative histological diagnosis of breast cancer. FNAC or fine needle aspiration cytologies is still used by many. It is not, I would not call it wrong assessment of a breast lump or diagnostic assessment of breast lump. However, it is certainly not the gold standard today. The gold standard is core needle biopsy, because FNAC has certain drawbacks or limitations. One cannot reliably grade the tumor, and certainly it is not possible to evaluate for the essential biomarkers of estrogen and progesterone receptor and HER2/neu with cytology specimen, which is easily possible with core biopsies. At times, you have patients who have indiscrete or non-palpable lesions in the breast, where one may have to use image-guided percutaneous biopsies, the very same core biopsy, but done with ultrasound or mammographic or stereotactic guidance. What must not be resorted to is routine surgical biopsy. The diagnosis of cancer must be established as far as possible before we take the patient to an operating room. So surgical procedure performed merely for diagnosis is not recommended and should be avoided as much as possible. So having established the diagnosis, having achieved the essential info or having received the essential histological and IHC information regarding the patient's disease, one can then plan the surgical treatment. Now, as I said earlier, there are two major components of surgical treatment, that of surgery of the breast primary and then surgical staging and treatment of any axillary nodes. So in terms of regarding the surgical treatment of breast primary, as I've been saying again and again, breast conservation is the preferred treatment, However, in certain other patients who are either ineligible for conservation or not willing for conservation, one would have to resort to a total mastectomy, which can be followed by breast reconstruction. In regarding the surgical staging of axilla or treatment of axillary node, the preferred way of staging the axilla in a patient who doesn't have overtly metastatic axillary node is by doing a sentinel lymph node biopsy and not a diagnostic or prophylactic axillary lymph node dissection. Axillary lymph node dissection should best be reserved for patients who either have grossly metastatic or palpable nodes which are metastatic, or where on basis of sentinel lymph node biopsy one has been able to establish the histologically the presence of metastatic and multiple metastatic axillary nodes. There are other alternatives to lesser invasive axillary staging procedures, and one of them is axillary reverse mapping, which can also be used. So let me now elaborate a little more about surgical treatment of the breast primary. This is dictated largely by the clinical stage of the patient and the tumor subtype or intrinsic subtype. So majority of patients who have a small T1 to T2 tumors with no skin or chest wall involvement and who are hormone receptor positive, they would be recommended to undergo primary surgery. And this surgery would be in form of breast conservation. Of course, there would be exceptions where mastectomy may have to be resorted to. Today, a large proportion of large T2 and N1 patients, especially those who are triple negative cancers or HER2 enriched cancers, and quite a few luminal B cancers or luminal B-like cancers, are subjected to neoadjuvant systemic treatment. And then, after suitable downstaging of the tumor, one can then treat them with post-neoadjuvant chemotherapy breast conservation. Large tumors, T3, more than 5 centimeters in size, and of course the locally advanced cancers, majority or almost all of them, they are treated with neoadjuvant systemic treatment, and a small proportion of highly selected ones who have responded very well to neoadjuvant systemic treatment can then be offered neoadjuvant, post-neoadjuvant chemotherapy breast conservation, but quite a few of them, rather majority of them, would require mastectomy. Because I am limiting this discussion to early stage cancers, I will not go on to discussing the rest of them, locally advanced and inflammatory cancers, which are usually treated with mastectomy and not conservation. So conservation is the rule, should be the rule. Mastectomy should be the exception. It may not always be possible to conserve breast in patients with early stage cancers, but we must strive to conserve the breast in as many early breast cancer patients as possible. This breast conservation surgery can be done as primary procedure, which means surgery is the first of the multidisciplinary treatment or multimodal treatment, or it can be post-neoadjuvant systemic treatment breast conservation surgery. More and more patients are being offered oncoplastic breast conservation surgery, and I'll try to elaborate a bit more on this concept of oncoplastic surgery, which I feel is very useful to the extent that I feel it is essential for all breast surgeons to know the concepts and techniques of oncoplastic breast conservation surgery. What is essential while doing breast conservation surgery is to achieve infiltration-free surgical margins, which means that while we are excising the breast tumor, conserving the breast, we have to be sure that we are not leaving behind any cancer cells. The margins or the surgical margins are free of any invasive or in situ cancers cells, and thus we can achieve acceptably low local recurrence rates. The current guideline to achieve this is that we strive to have no ink on the tumor margins, which means once you have taken out this specimen, surgical specimen, with wide margins, you ink the margins, and then on histology, the pathologist must not be able to find any ink on the tumor margins. In other words, it is no longer essential to have 1 centimeter or more, or even 5 millimeter or 2 millimeter wide margins when we are dealing with invasive cancers. For in situ cancer, one must have minimum of 2 millimeter of margins. As I said earlier, there are patients where we may have to resort to mastectomy, and this is when if the patients are ineligible for conservation or they are unwilling for conservation surgery. What is breast conservation treatment for breast cancer? It is indeed the standard of care for majority of early breast cancer patients and should be offered to appropriately selected patients who have early stage disease which is of a low risk, which has a low risk for local recurrence. And these patients must not have any contraindications to radiation therapy, because breast conservation treatment has two components: surgery and then radiotherapy. The way it is done is to do a wide local excision. Whichever quadrant or location in the breast the tumor may be, the surgeon would remove the tumor along with margins of normal breast parenchyma all around. So if for a moment, let's assume we have a spherical tumor. So the idea is to remove that sphere along with normal breast parenchymal tissue all around, all 360 degrees around. Often, or at times, one can resect out one whole quadrant or a segment of the breast. So these are some terms used at times: quadrantectomy, partial mastectomy, segmental mastectomy. But a vast proportion of breast along with the skin and nipple complex are preserved, and that is what breast conservation surgery is. While doing this, we are not compromising on the survival of the patient. Uh, the ipsilateral breast tumor recurrence rates or chest wall recurrence rates or in breast tumor recurrence rates following breast conservation are somewhat higher. However, the overall survival with breast conservation is better compared to mastectomy. And I would like to emphasize this a little more, that conservation results in not just equal survival for patients as compared to mastectomy. It results in better overall survival as per the recent data that we have. As I said earlier, the two essential components of breast conservation therapy are surgery and then taking care of the residual breast by radiotherapy to reduce the probability of local recurrence. Breast conservation treatment for breast cancer has been established based on very high quality scientific data, trial data. There are a number of such trials. NSAPP 06 was one of the largest and the earliest trials. French trial, the Milan trial, EORTC, Danish, NCI. There are any number of trials which compared the survival and the local recurrence rates between patients who underwent either breast conservation treatment or modified or even radical mastectomy. Without exception, all of these trials established equivalent survival rates, overall survival rates at 10 years, at 5 years, and even at 20 years. Of course, majority or rather many of these reported relatively higher local recurrence rates following conservation. But such a recurrence in majority of trials was not reported to result in excessive mortality. So now, as I said, NSABP 06 trial was one of the first and largest trials. The updated 20-year results of this trial were published in 2002 in NGN. And here, these Kaplan-Meier charts are showing you some key results from this NSABP 06 trial. On the leftmost chart, you can see many-fold higher incidence of local recurrence if the patients were to undergo only lumpectomy. This trial had three arms. One arm was lumpectomy alone without radiation. The second arm was lumpectomy with irradiation. And the third arm was total mastectomy. So, in terms of local recurrence rates, if the patient was treated with lumpectomy with radiation, the local recurrence rates were less than 10% at 5 and 10 years, and they were acceptable. However, without lumpectomy and without radiation, the recurrence rates was much higher. But the key result here in this trial were these overall survival rates, the survival between between patients and receiving total mastectomy and breast conservation, which means lumpectomy plus radiation, were almost identical. However, patients in the same way, the distant disease-free survival was no different between patients receiving total mastectomy and lumpectomy plus radiation. The disease-free survival again was no different between these two. So this trial and its updated result established safety of breast conservation treatment vis-a-vis mastectomy in terms of overall and disease-free survival rates. The same was true with Milan trial. Again, the updated 20 years results were published in 2002. The 20-year results showed that there was a higher incidence of local recurrence in breast conservation with radiation group compared to Halsted mastectomy, but there was no difference in the overall survival, disease-free survival, and the distant disease-free survival between the two groups. Well, this is as far as establishing relative safety of breast conservation compared to mastectomy. But the recent data of various trials and population-based and registry-based studies is establishing another interesting fact, and that is patients who are treated with breast conservation, they have better overall survival compared to patients who have undergone mastectomy. In the initial few studies, there were concerns regarding selection bias. Perhaps we are not comparing similar patients, and that is why patients with higher risk disease undergoing mastectomy have poorer survival. However, with numerous recent trials and studies which have used propensity score matching or even randomization, breast conservation has recorded better overall survival compared to mastectomy. Here is one example, the Danish Breast Cooperative Group population-based study. It reported a certainly better survival rate in patients receiving breast conservation compared to those who underwent mastectomy. There are numerous other observational studies published in very high quality journals. And to the extent that a very recent 2023 publication from British Columbia reports that even the local recurrence rates are no worse in patients treated well with breast conservation treatment compared to those who have undergone mastectomy. So today, we have sufficient data to believe that breast conservation doesn't compromise on safety of patients, neither in terms of their overall survival, in which regard breast conservation offers better results, nor in terms of local regional recurrence rates. And these are the results from this study from British Columbia published very recently. And both in node negative patients and node positive patients, the survival rates and the local recurrence rates following breast conservation with radiation, high quality contemporary radiation therapy was better compared to patients receiving mastectomy. There are a few contraindications to breast conservation, which are actually very few now. The most common in our own practice and experience is unwilling patient. The patient is scientifically, clinically well eligible for conservation, but for some belief or misbelief in certain myths, the patient wants to have a total mastectomy. And that's the commonest contraindication today in our experience for breast conservation. However, there are certain true contraindications like multicentricity. Multiple tumors located in different quadrants, they're quite far away from each other, say more than 5 centimeters. Diffuse indiscrete microcalcifications, indiscrete tumor, extensive intraductal component, which is perhaps it should be called as a relative contraindication, and contraindications to radiotherapy like collagen vascular disease, pregnancy, etc. These are the patients who cannot be offered conservation treatment. Here is a very quick example of how breast conservation surgery is done. One may not need to excise any skin. Appropriate skin incision is used. Minimal flaps are raised. We perform what we call as a no-see surgery. This was a relatively or rather very small tumor. So the idea is not to see the tumor at all. Remove the tumor with an envelope of normal breast parenchyma all around and then subject it to histology. While doing breast conservation surgery, you remove all the tissue, all the parenchymal tissue, right from subcutaneous fat down to the pectoral fascia, and this helps in avoidance of any need for re-excision of any deep infiltrated margins. The specimen is then oriented using sutures and other means, and it can be bisected. As you can see here, this is the intact tumor. This is a long suture denoting the long lateral margin, a short superior suture, and a double intermediate length superficial margin. And then on the bisected specimen, you can see this grayish white or gritty white tumor at the core of the specimen, surrounded by normal breast parenchyma all around. This is a bisected specimen. This is what we want to remove while doing a wide local excision for breast cancer. Margin assessment is an important and essential component of breast conservation surgery. What you do is remove this specimen, send it out for histology. It can be either intraoperative frozen section histology or just paraffin section histology, where the pathologist would assess for all the lateral margins, which means the lateral, medial, superior, inferior, superficial, and deep margins. And if any of these margins are found infiltrated with cancer cells, invasive or in situ, that margin needs to be re-excised to achieve clear margins. If, however, there is extensive infiltration, or even after multiple re-excisions, there is still infiltration, then one may have to resort to mastectomy in abundant breast conservation. But this is an essential step of breast conservation surgery. One can use some of the intraoperative assessment tools for margin assessment. We routinely use full section histology. One can use intraoperative specimen radiography or mammography. And there are certain other things like margin probe, which can help us detect infiltrated margins intraoperatively. At the end, the idea is to achieve infiltration-free margins with good enough cosmesis. The very tenet or very basis of doing breast conservation surgery is to conserve a well-shaped entire breast, maintaining good contour and symmetry. So here is an example of this patient who has undergone breast conservation surgery for a tumor located in upper outer quadrant and is now undergoing radiation treatment. And what you can appreciate is an intact breast shape, contour, and quite a good symmetry as well. Oncoplastic breast surgery. What is this new entity? Relatively new entity. This is a single operation incorporating an oncologically sound procedure for a breast tumor with a plastic reconstructive procedure to ensure invasion-free margins, yet achieving cosmetically appealing or acceptable outcomes in terms of maintenance of breast contour symmetry. And this procedure or this group of procedures facilitates breast conservation in patients, even though they may be having large tumors, to achieve infiltration-free margin and good cosmetic outcomes. And there are two different ways of doing it. One is tissue displacement, and the other is tissue replacement. Tissue displacement, as the name suggests, we displace the parenchymal tissue to fill in and recontour the breast. And as the name suggests, tissue replacement is where we borrow tissue from outside the breast, like a mini latissimus dorsi flap or other perforator flaps, to fill in a defect which we may have created by way of wide excision of the tumor. Round block is one of the most basic oncoplastic level 1 oncoplastic procedures where we use a round block or a two concentric circular incisions, epidermal incisions, maintaining the dermal continuity and removing tumors which are close to the NEC using this technique. There are a myriad other techniques available which unfortunately I will not be able to go into details because of limited time available, but this is an example of a volume replacement oncoplastic procedure where a mini latissimus dorsi flap has been used to create the contour or maintain the contour of in a relatively small breast after excision of a large tumor. So as I said, there's multitude of techniques of level 1 and level 2 oncoplastic procedures which can be used based on the location of the tumor within the breast, the volume of tissue excised, and the contour and stature of the patient's body. Neoadjuvant systemic treatment is being used more and more in early stage breast cancers today, and as I said earlier, especially in patients with triple negative and those with HER2 enriched cancers. Following neoadjuvant systemic treatment, patients who are downstage to a relatively smaller disease, they are more amenable to breast conservation surgery. Also, we can select out patients for appropriate adjuvant treatment post-surgery with downstaging. For example, in patients who are triple negative and after neoadjuvant systemic treatment, they have residual cancer burden, they can be offered capecitabine in adjuvant setting. Patients who are HER2 enriched, who are downstage in early stage, who are downstage from say T2 to T1 or T0, again we can tailor their adjuvant treatment. Those who have no residual cancer, they can be treated only with trastuzumab. However, those who have residual HER2 enriched cancer, they can be treated with trastuzumab emtansine or TTM1. So again, the idea is to tailor the treatment as per the need of an individual patient. And then these patients can be subjected to post-neoadjuvant systemic treatment breast conservation. There are certain strategies which are useful or highly useful while doing post-neoadjuvant systemic treatment breast conservation. One of them is marking the tumor with a radiopaque marker before initiation of neoadjuvant systemic treatment. And this marker, eventually, when you are operating after good downstaging of the disease due to neoadjuvant chemotherapy, helps you find the tumor footprint which has to be excised. In this setting, post-NSCT setting, margin assessment is somewhat more tricky compared to margin assessment in a patient who is undergoing primary breast conservation surgery. So one has to put specific emphasis and attention to this. In patients who are undergoing, select patients who are undergoing post-NSCT breast conservation, the procedure itself is safe compared to patients undergoing primary surgery, primary breast conservation. However, the concerns remain of a possibility of higher local recurrence rates, so these patients need to be followed very carefully. The follow-up following breast conservation is on account of the possibility of recurrence in the breast and appearance of new primaries in the conserved breast. Of course, there are possibility of contralateral breast primaries and a metastasis as well. So a careful assessment for a recurrent disease in the follow-up is essential. It is done by a combination of clinical assessment and imaging. And while doing this, one has to be aware that there would be quite a bit of scarring and changes which are not because of a residual or recurrent cancer, and they would still be there. So do not consider any scarring, any induration, any lump in the follow-up as a recurrence. Of course, evaluate it appropriately, but do not jump on to diagnosing recurrences. At the same time, do not ignore any suspicious lesions. Well, that is as far as breast conservation is concerned. There are still patients where mastectomy would be required. These patients are those who refuse breast conservation, where you have found involved or infiltrated margin even after re-excision, those who have multicentric breast cancer, those who have diffuse DCIS, patients who have recurred after breast conservation, some of them would, or many of them would require mastectomy. Patients who are carriers of BRCA mutations, connect those who have contraindication to radiotherapy or those who have received radiation to breast and chest wall earlier. These are patients who would require mastectomy and not conservation. While doing mastectomy, certain technical issues have to be taken care of or kept in mind. Place of horizontal elliptical incision include while doing a total mastectomy, horizontal elliptical incision, raise flaps in the right mastectomy plane, that is the plane between the superficial subcutaneous fat and the deeper parenchymal fat, which is large globules of fats. Raise the flaps right from the inferior margin of the clavicle down to the inframammary fold and parasternal margin laterally to the anterior border or medial border of the latissimus dorsi muscle. When you're doing a modified radical mastectomy, which means you're also doing axillary dissection simultaneously, you remove all the nodes and fibrofattic tissue and lymphatics in levels 1 and 2 of axilla. I'll come to that later. However, in as many patients as possible, we try to do sentinel lymph node biopsy. And at the end of this mastectomy procedure, one must achieve a tension-free closure with a suction drainage, both of the axilla and the mastectomy flaps. A well-healed mastectomy scar should look like this, with no tension and no excess skin or subcutaneous fat or tissue. At times, one for especially in patients who are desirous of it, one can do primary breast reconstruction like it was done in this patient using a latissimus dorsi flap. Of course, there are a number of other techniques for whole breast reconstruction, including DF flap or tram flap and artificial, prosthetic breast can be used. Some patients who are in between need patients for breast conservation and mastectomy, or they have certain specific indications like mutation carriers who are undergoing prophylactic or risk-reducing surgeries or mastectomies. They can be offered some form of a conservative mastectomy where we are preserving the breast skin or nipple areola or both, or total nipple sparing mastectomy. There are various incisions and techniques available. Now, let me quickly talk about how do we manage surgically the axilla in a breast cancer patient. The minimal surgery required in these patients is a sentinel lymph node biopsy. However, selected patients would require uh, axillary dissection as well. Axillary surgery is an essential component of breast cancer surgery. It provides the vital staging information, which is helpful in prognosticating the patient and in adjuvant treatment planning. It contributes to the local regional control of the disease. However, it comes at a bit of cost of morbidity. So again, the extent of axillary surgery depends on the clinical stage of the axilla. in patients with clinically N0 disease or uninvolved axilla, sentinel lymph node biopsy is the way to go. It can be done primarily, that means before any systemic treatment or after the neoadjuvant systemic treatment. In patients who have metastatic node, which are mobile or CN1, clinical N1 stage, they can either undergo an axillary lymph node dissection as a primary procedure, or they can be subjected to neoadjuvant systemic treatment. And then if they become N0, YCN0, post neoadjuvant chemotherapy N0, they can be subjected to sentinel lymph node biopsy or targeted axillary dissection. And I'll come to these details a little later. Of course, patients who have locally advanced cancers, like those with N2 or N3 disease, they would undergo neoadjuvant chemotherapy and axillary dissection. So the complete axillary dissection is current in current era. We believe level 1 and 2 dissection is complete, and level 3 dissection is reserved only for patients who have bulky nodes in the level 2 or those who have enlarged and metastatic nodes in level 3. At the end of the procedure of axillary dissection, what one wants to do is not skeletonize the axillary vein, leave a bit of fascia on top of the axillary vein, and preserve the three important structures: the nerve to latissimus dorsi, the thoracodorsal pedicle, and if possible, the intercostobrachial nerve. So a complete axillary dissection is defined when the pathologist has been able to assess at least 10 lymph nodes in the axilla and report on whether they are metastatic or not. The procedure of axillary dissection comes with a substantial probability of morbidity or complications. These complications or morbidity can be seen up to 50% of all patients. They can be early, like seroma, or delayed, like shoulder motion restriction, arm edema, and pain, shoulder pain and breast pain. Axillary dissection for clinically N0 disease is certainly an overkill. One does not need it in majority of N0 patients. Roughly 30 to 40% in the worst case scenario of these patients would turn out to be having metastatic nodes when subjected to axillary dissection. So in other words, almost 2/3 of all such axillary dissections are done for no good reason. They are unnecessary. Yet the conventional way of treating these patients used to be axillary dissection as an essential component. The alternative we now have is what is we call as sentinel lymph node biopsy. The concept of sentinel lymph node biopsy is based on the systematic flow or logical stepwise flow of lymphatics from any tumor-bearing area within the breast. There are efferent lymphatics to a node which take lymph from a tumor-bearing area, and then there are efferent lymphatics. So the idea of sentinel lymph node biopsy is if we can selectively identify those nodes, those few nodes which are likely to receive efferent lymphatics from a tumor-bearing area, biopsy it, and then based on this biopsy, stage the axilla. If there is no extensive lymph node metastasis, we can spare the patient of full axillary dissection, achieve axillary staging by a minimal procedure and not a full axillary dissection. The best way to do this procedure, the gold standard way, is to use dual dye. That means using a blue dye, such as methylene blue, and using a radiopharmaceutical, which is injected 12 to 24 hours before surgery, and using a handheld gamma probe, like you can see here, one tries to look for a blue and a hot node. A blue node which has concentrated or attracted the blue dye that you have injected into the breast, and hot node which has concentrated the radiopharmaceutical which has been injected into the breast. So using this combination of dyes, one can identify the sentinel lymph nodes in more than 95% cases, and achieve robust staging of the axilla in with more than 90% certainty. There are other options available like fluorescent dyes such as ICG or fluorescein, and a few other methods. Uh, Sentinel lymph node biopsy is the current standard of care for staging of CN0 axilla. It is an effective method to detect axillary lymph nodal metastasis and helps us reserve axillary dissection, which is relatively more morbid, only for such patients who have substantial lymph nodal burden in the axilla. The rates of local or regional recurrence in patients treated with sentinel lymph node biopsy alone, and so they were spared of axillary dissection. They, as the local recurrence rates as well as overall survival rates in various trials and studies have been reported to be identical, no worse, no higher, compared to patients treated with prophylactic axillary lymph node dissection. And there are numerous advantages of sentinel lymph node biopsy over axillary dissection. Besides being accurate and reliable, it helps us spare axillary dissection in patients who do not have metastatic disease. And there's substantial evidence today to back the routine practice of sentinel lymph node biopsy, including some long-term data as well. So sentinel lymph node biopsy, it, it reflects, or it is indeed a paradigm shift in the way axilla is managed surgically in clinically node-negative axilla. The conventional prophylactic axillary dissection is no longer appropriate. The contemporary way is to do sentinel lymph node biopsy. And there is even a view now, and very widely professed view, that even in patients who have limited number of metastatic sentinel lymph nodes, one or two, one may not need to do axillary dissection or completion axillary dissection. Again, it is backed by some trial data. However, this data is not as strong, as robust as data for avoidance of axillary dissection in N0, PN0 disease. The whole of this data is so compelling, and the benefits are so compelling, that almost all the guidelines today, they advocate sentinel lymph node biopsy as the standard of care axillary staging procedure. And in patients who have limited sentinel lymph node metastasis, avoid any axillary dissection, reserve axillary dissection only to patients who have substantial metastatic burden in the axilla. That means more than 3 nodes in the metastatic nodes in the axilla. Following neoadjuvant systemic treatment, one needs to have a little more carefully thought out management plan for the axilla. The conventional approach has been again to do axillary lymph node dissection. However, now we have an alternative of doing post NSCT sentinel lymph node biopsy in patients who had a primarily N0 disease, or even those who had primarily N1 disease but who have converted to YCN0, post NSCT N0 axilla. And by doing sentinel lymph node biopsy and achieving axillary staging, we can reserve axillary dissection only to patients who have residual metastatic disease in the axilla. So even for post NSCT axilla, staging can be achieved very well with sentinel lymph node biopsy. However, this comes with a bit of caution. The caution is essentially because chemotherapy or systemic treatment can induce changes in the lymphatics, and this may not result in as accurate staging of axilla using sentinel lymph node biopsy as primarily in patients who are undergoing primary surgery. And if there are blockade to some of the efferent and efferent lymphatics of the sentinel lymph nodes, they can be skip metastasis, and so it may not be always possible to find the sentinel lymph nodes. So that is the reason why post-NSCT sentinel lymph node biopsy is not as straightforward as primary. We compared the results of primary sentinel lymph node biopsy with post-NSCT sentinel lymph node biopsy in stage 3 cancers. There are a number of studies which have compared or which have reported on the identification rate and false negative rates of sentinel lymph node biopsy when performed following neoadjuvant chemotherapy. Some of the important ones are the studies are Sentina, the ECOSOC Z1071 Alliance trial, and the SNFNAC Australia New Zealand trial. This was the North American trial, and then there's a FNAC Australia New Zealand trial, and the two French trials, the Genia 1 and Genia 2 multicenter trials. All these trials, they have brought about data relating the sentinel lymph node identification rates as well as the false negative rates. The using conventional methodology as we use for primary sentinel lymph node biopsy, the false negative rates achieved by these trials were not acceptable. The gold standard or the minimum acceptable standard of false negative rate is less than 10%. However, using the standard techniques, all these trials reported higher than 10% false negative rates. So they tweaked their methodology to some extent. And now what is recommended is that if one is able to remove at least 3 or more sentinel nodes, one can achieve less than 10% false negative rate. One must use two tracers. One cannot use just one dye. One has to use 2 dyes minimum, and then assess for metastasis using IHC to detect any YPN0I, which is isolated tumor cells. So that is a way of reducing false negative rate, and one can achieve a reasonably reliable staging of axilla even in post-NSCT setting. There's another concept of focused or targeted axillary dissection. This is employed when we are dealing with patients who present primarily with a mobile metastatic axillary node. Before initiation of neoadjuvant chemotherapy, one puts in a clip or some other, say, radioiodine seed or MAG seed into this metastatic node, following which the patient undergoes neoadjuvant chemotherapy. And then after the neoadjuvant chemotherapy, this seed or clip is then targeted, removed selectively, and subjected to histology, along with the sentinel lymph node biopsy. This is the concept of targeted axillary dissection. Using this technique, one can reduce the false negative rates of post-NSCT sentinel lymph node biopsies substantially. And there have been a number of such studies in recent time using various methodologies, like the most common one is ultrasound guided core biopsy and clipping. However, the alternatives are carbon tattooing, radioiodine seeds, and supermagnetic iron oxide seeds or MAG seeds. Following neoadjuvant chemotherapy, these are targeted, removed along with sentinel lymph nodes, and this reduces the false negative rates by half. So I have so far talked to you about all the management strategies or surgical treatment of breast primary and the axilla. Both are equally important to take care. And to summarize in the end, surgical management of early breast cancer is the first essential or the most essential part of multimodal breast cancer treatment. What is needed is to have a protocol-based comprehensive treatment plan, both for the breast primary and the axilla. Breast conservation surgery is the desirable treatment in majority of early breast cancer patients. Oncoplastic surgical techniques help us achieve it well, achieve good results easily in majority of patients. The procedure performed usually is a wide local excision followed by margin evaluation by pathology, and radiating the rest of the breast to reduce the probability of local recurrence. However, certain patients who are either not eligible, not appropriate candidates for breast conservation, or those who are not willing for breast conservation may still need to have mastectomy performed. Post-neoadjuvant chemotherapy breast conservation can be performed safely, and here again, oncoplastic techniques help us achieve good results. Similarly, for assessment of axilla in known negative cancer patients, sentinel lymph node biopsy is the appropriate procedure. Patients who have metastatic sentinel lymph nodes or those who have worse than N1 disease, they would require axillary dissection. The same thing can also be offered selectively to patients following neoadjuvant chemotherapy, in where again one can detect metastatic disease in the axilla using sentinel lymph nodes, and only if there are metastatic nodes one can resort to axillary dissection. So, indeed, the contemporary surgical approach to breast cancer treatment is less is more. Uh, I've explained to you, I've demonstrated to you how, what basis we have to say that overall survival of breast cancer patients following breast conservation is better compared to patients who are treated with mastectomy. Similarly, a less invasive, more conservative sentinel lymph node assessment of the axillary node is so much better compared to axillary dissection for early stage breast cancer patients. So I'm sure there would be some questions or even comments, and I'll be very happy to address those. Over to you, Dr. Sabaratnam.
Thank you, sir. From the Association of Surgeons of Rural India, we thank you immensely for this wonderful lecture, and it covered everything. I am opening this for discussion. Dr. Vishwak, you want to make?
Good evening, sir. Uh, Sir, it's a very enlightening lecture, sir. Thank you so much for the wonderful lecture. It's always been a pleasure to listen to your talk. Sir, I have a couple of questions. Like, one is like if on index presentation, if patient have N2 or N3B, N3 disease to start with, and post neoadjuvant chemo, if the nodal burden has come down, like will it be still seen as a relative contraindication for breast conservation surgery because of the nodal burden at index presentation, or can we go ahead with BCS in that case?
Okay, so the nodal stage to a large extent does not dictate how we address the breast primary. It of course has a bearing on how we address the axilla post NSCT, but the specific scenario you posed, that patient was N2 or N3 to begin with, and following neoadjuvant chemotherapy, the patient has become N0 or whatever, but can we offer them conservation? Certainly, yes. What cannot be offered to these patients in this scenario is sentinel lymph node biopsy for axillary staging, because with N2, which means matted nodes, multiple matted nodes, or even N3, the axillary lymphatic anatomy is distorted. In trials and studies, what has been reported is that sentinel lymph node identification rate is low. In our own study, we found it was as low as 75%, 78%, and the false negative rates are high in these patients, and so one cannot reliably stage the axilla using sentinel lymph node biopsy. So one should not offer sentinel lymph node biopsy to these patients. But when it comes to deciding whether breast conservation is appropriate for these patients, it certainly is. We can safely offer them breast conservation.
Thank you, sir. Thank you, sir. So my other second question is like, what is your take on like omitting sentinel lymph node biopsy in hormone receptor low grade tumors? The recent studies which came out. So
Yes. So thank you for bringing that up. That is, I would say, the next level of conservation, next level of conservatism in breast cancer surgery. The sound trial that you're referring to, that and certain others, other trials, studies, they have evaluated the safety of omission of even sentinel lymph node biopsy in patients with very low risk disease. What are these patients? These are patients more than 65 years age, elderly patients with high estrogen receptor positive cancers and small tumors with no metastatic, no suspicious nodes seen on ultrasonography, which is a focused ultrasound of the axilla. So all in all, these are really low risk for metastatic nodes in the axilla, and these are patients who are treated with otherwise with good quality surgery and in all likelihood whole breast radiation. So the probability that you have either missed a metastatic node, or if there was a metastatic node, it has been left untreated or unaddressed, is extremely low. In these patients, one can selectively omit even doing sentinel lymph node biopsy. At least the sound trial has reported no excessive local recurrence and certainly no worse survival in these highly selected patients.
Thank you, sir. Thank you so much, sir. Thank you, Sabha, sir, for letting me to ask questions. Thank you, sir.
Anyone else want to interact with sir? Dr. Rinal, you like to make a comment or ask anything from sir? If no more questions or comments, anyone?
So I
Okay,
guess
sir. Actually, thank you, sir, for the Rinal has sent a text message. So this one, I don't think anybody. I think they're tired at the end of the day, sir. So
yes. Okay. So thank you very much. It was. I hope I've been able to convey or perform the job that you expected me to do. And I thank the Association of Rural Surgeons of India once again for this opportunity.
thank you, sir. Thank you so much. And the third lecture series, we will meet next week with another interesting lecture. Till then, thank you so much. And thank you again, sir, for helping us.